Welcome, everybody. Happy Wednesday evening. Thank you so much for joining on this evening. We've been looking forward to this for a really long time. We're really extremely lucky to have Heather with us tonight. Before we get started, I do want to point out a couple of really great things. One, that is that you can get CEU credit for attending tonight. So we can look at that. We'll be giving you a link to take the post test after the roundtable this evening, and then we'll send you your certificate via email in about a week. You do have to achieve a 70% or greater on that post webinar quiz to get the credit, and then that can just be submitted. So that's a really great thing. Lots of hard work behind that to get the CEU accredited. We'll look to continue that so that you can get credit for attending tonight, like I said. The other thing that I want to start with before we really get into the nitty gritty is we are in conference season. So if you have not yet registered for the SVN annual conference in mid-June, please hit the website and we would love to see you there as well. There'll be some really, really great topics, really great things going on. And then you can see there, if you scan that QR code for SVN membership, you will get all of the benefits of membership, including mentorship, conference, all of the good things that we get to do as members. So if you're not yet a member, please look into that. For time's sake, I will now introduce our speaker this evening. Welcome to Heather Pernay. Heather is with us at the University of Toledo Medical Center. So I've had the pleasure of working with Heather directly and personally for over 3 years now. She is a wound and vascular nurse practitioner. She has taken a special interest in heritable aortic diseases and done a whole lot of research and work and networking to learn more about that. So we're really lucky to have her expertise with us tonight. Her interest in connective tissue disorders and some of the heritable diseases started about a year ago when she was reading about Ehlers-Danlos syndromes. These things are oftentimes not all that common, but really great to know about. And when you're looking, you certainly can find them. So she's going to talk about some of the gaps in care and what this kind of all looks like tonight. Some personal things about Heather so that you can get to know her. She loves to travel. She lived in Jordan and in Vietnam for a total of 4 years. So she also brings with us a wealth of just life experience and knowledge. So welcome, Heather. Thank you for being here tonight. After Heather's presentation tonight, we will have some Q&A. If you can put your questions into the Q&A directly, we'll go ahead and answer them that way. Thank you.
All right. Thank you, Karen. I have some thank yous before we get started. As Karen said, I've reached out to a lot of people who are really experts in the field just to say, hey, I'm interested in learning more. Can I come shadow you? Can we talk? So I really feel fortunate to have had that opportunity. And also apologies, I had difficulties with my slide sharing. So I will have to say next slide after every single one. And thank you, Mo, for putting the slides up for me. So huge thank you to my mom and my husband who have really helped me out to have extra time to be able to do more research and put together this presentation. Thank you to Karen Bauer and Dr. Nazal. They've really helped to motivate me to pursue my interest and also to educate others, which I'm really passionate about. Thank you to Dr. Kalahasti. He's the director at the Cleveland Clinic's Marfan Syndrome in Connective Tissue Disorders Clinic, and he's actually one of the authors of the ACC-AHA Aortic Disease Guidelines, which we'll be touching on tonight. Thank you also to Dr. Roselli. He's a cardiothoracic surgeon, and he's the director of the Aorta Center at the Cleveland Clinic. Both Drs. Roselli and Dr. Kalahasti let me shadow them at Cleveland Clinic for a day, just so I could learn as much as I could. Also, thank you to Dr. Shireen Shalhoub. She's a vascular surgeon, an associate professor of surgery in the Division of Vascular Surgery, and associate professor of molecular and medical genetics at Oregon Health and Science University. And she also happens to be the principal investigator for the Vascular EDS Collaborative Natural History Study. Thank you also to Dr. Claire Francomano. She's a geneticist and professor of medical and molecular genetics at Indiana University. She's really involved in the Ehlers-Danlos Society, and she facilitated all of the EDS echo sessions where I learned a lot of valuable information, including how to go about ordering the genetic testing for those who we suspect have HTED. Thank you also to a couple different genetic counselors who I've had the pleasure of speaking with. Molly Stetler, she's with Invitae, Brad Power with Ambry, and Rajani Atre with the University of Michigan. Thank you, everybody. And without further ado, we can get started. Next slide. And sorry, can you go to the objective slide? For some reason, I'm not seeing it on my screen, the objectives one.
Are you seeing it, Heather?
No, I just see the connective tissue disorders, vascular disease, and genetic testing original slide.
Okay, I am showing the objectives on my side. Do you want to try maybe sharing your screen and seeing?
Yeah. Okay, let me try one more time to share. Are you able to see the objective slide now?
So we can still see like we could before, maybe instead of doing the slideshow, because we can see the objective slide with your slides on the side, maybe go ahead and leave it in this mode and click down the slides, if that makes sense, so that we can make sure that you have enough time to get your content in.
Okay, so just do it like this and then just click enter to show the slides as I normally would.
Yeah, because I think there's something going on with regard to just having that slideshow view that isn't allowing you guys to show.
Okay, I apologize, everybody. I don't know why on my screen it's showing just the slide. But without further ado, I will get started. So just to go over the general objectives is to learn what HTAD means. We'll go over some aneurysm and dissection basics. We'll know when to suspect HTAD. We'll identify phenotype features of syndromic HTAD. We'll know how to obtain the genetic testing for which we order the aortopathy panel. And then we'll know where to refer the patients with HTAD or even suspected HTAD. And those would be, the closest expert center to you. You'll have a general knowledge of the medical management of those with HTAD in terms of their aneurysms and dissections. And there's a long list of resources at the end for yourself and for your patients. So HTAD means heritable thoracic aortic disease, and this is a genetic or heritable condition characterized by occurrence of aortic events, and these are mainly aneurysms or dissections. It most commonly involves the aortic root and the ascending aorta, though it can also affect other places in the aorta, as well as peripheral aneurysms. These pathogenic variants in certain genes can lead to other aneurysms like we were just talking about. You can have cerebral aneurysms, the peripheral aneurysms like the iliacs, the popliteal, even abdominal aortic aneurysms. The abdominal aortic aneurysms are mostly found in people who have high risk, generally speaking, for aneurysms. So, the people who are smokers and have hypertension, hyperlipidemia, but sometimes you can see this in the HTAD population. It's important to note that with these HTAD genes, there is an autosomal dominant inheritance pattern. So if somebody has a pathogenic variant, they do have a 50% chance of passing this on to their children. And that's one of the reasons that, we want patients who we suspect might have HTAD to get the genetic testing because, there's a 50% chance that their children could have that genetic variant. Just going over some of the general anatomy of the aorta, you can see the aortic root here and the ascending thoracic aorta. Again, this is the area most commonly affected with HTAD. Then you have the aortic arch, and I do want to point out that when it comes to surgical repair, cardiothoracic surgery does repair from the aortic root to the end of the aortic arch. And then from the descending thoracic aorta all the way down to arteries that you can't see because they're not on the slide, that's where vascular surgery comes in for the repair.
So Heather, real quick, sorry.
Yes.
Take your, do escape, take your screen off the slideshow because we can still only see your objectives. And yes, give the talk like this. So go back to your, the aneurysm slide and give it like that so that we can then see the slides. Is that good?
Okay, so just like keep it here.
Yeah, and then click
Okay.
the slide on the left so we can see the one on the right. Because for whatever reason, I think the issue is when you're showing the slideshow view.
Got it. Okay, I'm sorry. And this will be available also for recording, and then maybe possibly we can send this to people to go through themselves. And okay, thank you,
Yeah,
Karen.
we can splice it too, but kind of maybe do that, the anatomy one back over again so we can see the picture talking through it.
Yes. So here we have the anatomy of the aorta and its main branches. So right here you have the aortic root, and then you have the ascending aorta. Here you have the aortic arch. And it's important to note that basically from here, from the aortic root to the start of the descending thoracic aortic aneurysm is where cardiothoracic surgery comes in for repair. And then everything from the descending thoracic aorta down is where vascular surgery comes in for the repair. And this is another reason why you want to refer to an expert center with a multidisciplinary team. Just going over the basics of what a dissection is. It's a tear in the inner lining of the artery, the intima, and this allows blood to penetrate that middle layer, the media, separating the true lumen right here from the false lumen. And issues can arise when this false lumen gets too big and you're not getting enough blood flow, through the artery, and also that false lumen in that medial layer could block, let's say, the iliac artery and cause acute limb ischemia. So important to note that dissections are not always medical emergencies. Patients can have chronic dissections that we manage medically. We treat as needed depending on the symptoms and what we see clinically. Okay, going over the general definition of an aneurysm. Generally speaking, an aneurysm is an artery that's dilated to at least 1.5 times its expected normal diameter. It's important to note that this is not the case for the aortic root and the ascending thoracic aorta. So to give an example, a male in his 40s is going to have an aortic root that's 3.5 centimeters. If you multiply that by 1.5, you get 5.25. When it gets that big, you already want to repair it. You want to repair it when it reaches 5 centimeters. So this is a general rule, but I think the most important takeaway is that this doesn't apply to the aortic root and the ascending aorta. Another important consideration is that the size of the aorta can depend on the natural history, which also includes the average height of the person. And there are very specific algorithms, which I will not get into now, to determine, what that average size is, partially based on height. Signs and symptoms of dissection and aneurysm rupture, they can be pretty similar. So you can have sudden severe sharp tearing, ripping, or stabbing pain in the chest or upper back. I once had somebody describe a dissection of the aorta as a sharp tearing pain that kind of seemed like a zipper was being pulled down. You can have shortness of breath, fainting, dizziness, low blood pressure, sweating, confusion, loss of vision, rapid weak pulse. Again, we see a lot of the same with an aneurysm rupture. Sharp, sudden pain in the upper back that spreads down, pain in the chest, jaw, neck, or arms. And note that these can also really mimic the symptoms of an acute MI. So it's really important to identify these patients because maybe you have, somebody who is otherwise young and healthy. Let's say they're 25 years old, they walk into the ED with these symptoms. They might not be thinking that this person is having an aortic aneurysm rupture or dissection. So within the HTAD, you have two different categories. You have the syndromic HTAD and the non-syndromic HTAD. With the syndromic HTAD, these connective tissue issues, so to speak, they affect multiple organ systems essentially. And sometimes they will have features that you can identify just by doing a really good physical. some of the syndromic HTAD, Marfan syndrome, which a lot of you have probably heard of, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, arterial tortuosity, Sprintzen-Goldberg syndrome, LOX-related thoracic aortic aneurysm, and smooth muscle dysfunction. The three that we'll be focusing on, just going over the syndromic phenotypes, will be the Marfan's, Loeys-Dietz, and vascular EDS. Now, the non-syndromic HTAD, these are the connective tissue disorders, the HTAD, that don't affect multiple organ systems. So they really just affect the aorta, typically. With Marfan syndrome, the areas of the body most often affected when it comes to acute aortic events would be aortic root aneurysm, dissection, and a thoracic abdominal aneurysm. So when you're doing the physical on these patients, you want to look for these phenotype features. If they are very tall, if they have abnormally long and slender fingers, if they have scoliosis, if they have wrist sign, and I'll show you a picture of that in a minute, pectus deformities like pectus excavatum and pectus carinatum, ectopia lentis, myopia, a history of pneumothorax, flat feet with hindfoot deformity, or dural ectasia, a widening or ballooning of the spinal sac surrounding the spinal cord. This is not something that you would necessarily find on, doing a physical, but just looking into their medical history. I thought this was interesting that the dural ectasia is an often overlooked reason for inadequate spinal anesthesia. Just thought I'd add that interesting fact. So Loeys-Dietz syndrome most often affects the aortic and branch vessel aneurysms and dissections, including having arterial tortuosity. Arterial tortuosity doesn't necessarily mean that one is at increased risk of aneurysm or dissection, but it's a more common finding in those with Loeys-Dietz. Phenotype features are similar to those with Marfan syndrome: hypertolarism, which is widely spaced eyes, a bluish sclera, a bifitter broad uvula, and we'll see a picture of this in a minute, translucent skin with a visible venous pattern, and that visible venous pattern is especially prominent on the chest and abdomen, club feet, premature osteoarthritis, peripheral neuropathy, craniosynostosis, and dural ectasia again. For vascular EDS, this actually affects more than just the aorta and the peripheral arteries. You can also have a bowel rupture, uterine rupture, or spontaneous pneumothorax. Phenotype features, some of these again repeat themselves with the translucent skin. You might have easy bruising, prominent eyes, peripheral hypermobility, so that's usually affecting the hands and the feet, micrognathia, an undersized lower jaw, narrow nose. There again, you have the widely spaced eyes, acrogaria, a premature aged appearance of the hands. One might also have a carotid cavernous fistula. It is really important to note as well that not everybody with a syndromic HTAD have the same features. You can even have people within the same family who have the same genetic variant who have this variable expressibility, meaning that their phenotype features can vary greatly. So you can have one family member, and let's say they have the flat feet, they have dural ectasia, they have a visible venous pattern, peripheral hypermobility, scoliosis, all the things. They might have a relative who has the same gene variant, but has maybe one feature. So it's definitely not a one size fits all in terms of the phenotypes that they express. Here, just wanted to show you some pictures thanks to this HTAD patient pathway article in the European Journal of Medical Genetics. So here you can see we have imaging of aortic root dilatation. Here's the ectopia lentis. Here's the wrist sign where you take the thumb, you put it over the wrist, and then the thumb goes well over that first finger. You have flat feet, the hindfoot deformity, pectus excavatum. You have a visible venous pattern here. It's a little bit difficult to see. A lot of people will see, they have visible veins on their arms. That's normal. But if you have a prominent visible venous pattern, especially on the chest or abdomen, that is one of the phenotype features. Here you can see a very distinct bifid uvula, and here a very distinct example of arterial tortuosity. So obviously not everybody with a thoracic aortic aneurysm or dissection has HTAD. So we have certain criteria that we go by in order to identify these patients. So if someone has the syndromic features that we have just talked about, then, our radar is going up that this person might have an HTAD. Maybe we should consider genetic testing. Anyone who has thoracic aortic disease under 60 years of age and who has a family history of either the thoracic aortic disease or peripheral intracranial aneurysms in a first or second degree relative. Also, a history of unexplained sudden death at a relatively young age in a first or second degree relative. This I got from the ACC AHA guidelines on aortic disease, and I didn't see any specificity on the relatively young age. So I guess that would be one's discretion. I would think 40s, maybe even 50s. So here we have an algorithm taken from the ACC AHA aortic disease guidelines, really telling us again in a more visual way when to go about the genetic testing. So you might be wondering, okay, well, we know that, these aneurysms and dissections can have a genetic cause. They tend to run in family, so to speak. So why do we care about genetic testing? Well, there are a lot of different reasons, actually. There are some gene-specific considerations on when to do intervention for an aneurysm. For example, in Loeys-Dietz, there are actually specific guidelines on when to repair the aneurysm based on the exact specific gene that is affected. And again, going back to that autosomal dominant inheritance pattern, there's a 50% chance of passing it on to one's children. So if somebody has, let's say, a non-syndromic HTAD, where they don't have any physical features that would, let us know that this is suspected, we want to know if these people have a pathogenic variant so that they can undergo that next bullet point, the surveillance imaging, either an echo, CTA, or MRA, so that we can monitor the aneurysm and do an elective surgical repair. Why? They have much better outcomes than emergent surgical repairs. You do not want to go to the hospital if you have an acute type A aortic dissection, or possibly even a rupture. We want to identify these things before they happen and repair them. You also want to educate the patient on signs and symptoms to look for if they do have a dissection or an aneurysm, especially going back to, that young, otherwise healthy patient. I've actually heard stories in a lot of the webinars and education that I've done online, watching videos, etc., of otherwise young, healthy people going to the emergency department, and things aren't caught right away or they're misdiagnosed. And it's because, a dissection or aortic rupture is not the first thing that comes to somebody's mind. Prescribing the correct medications, which we'll talk about. Also, just wanted to point out the cost has significantly come down over the past decade. I heard one patient say 10 years ago, she paid $7,000 to get her genetic testing. Nowadays, it costs usually hundreds of dollars. So for these gene-specific considerations, for vascular EDS, and this is just an example, you want to avoid diagnostic angiograms. With VEDS in particular, the tissue is a lot more friable, so there's just a lot more surgical risk that comes with any kind of invasive procedure, even if it's endovascular, like a diagnostic angiogram. Because of the risk of colon rupture, you want to avoid those routine colonoscopies. Doesn't mean that they can never be done, but again, proceed with caution kind of situation. There are also special surgical repair principles for endovascular and open repair. Specifically, I know that this is for vascular EDS, again, because of the friable tissue. It might also apply to some of the other HTADs, but I know this particular, information I did get from a vascular EDS presentation. And as I had referenced earlier, for Loeys-Dietz, and this table comes from the ACC AHA guidelines, you can see the genetic variant here correlating with the presence of high-risk features, and then you correlate with the aortic diameter. So if you have, let's say, this genetic variant TGFBR1 with no high-risk features, you're going to repair when it's over 4.5, but some of these other variants, you're going to repair when you get just over 4 centimeters. And the guideline overall is repairing at 5 centimeters. So you can see that, it actually makes a pretty big difference. You really want to know what you're dealing with to know when to repair and before you get into the operating room. Just going over some general surveillance imaging, an echo provides a pretty good view of the proximal ascending aorta and portions of the descending aorta, but it's not ideal for visualizing like the aortic arch down. We have the CTA and MRA, just some things to consider: kidney function, obviously radiation exposure and pregnancy. And then for an MRA, you want to consider the implanted devices, possible claustrophobia. Do they have the ability to lay down long enough to get their MRA done? And kidney function again, because you're going to use that contrast. Another reason to do genetic testing, again, if you suspect the HTAD, is for medical alert bracelets. So if someone is, let's say, found down, if they've had a rupture or an acute dissection, it's good for them to have a medical alert bracelet with that diagnosis on that medical alert bracelet. Again, going back to patient education, you want them to know the signs of the arterial dissection, aneurysm rupture. In the case of, for example, VEDS, they're at higher risk of uterine rupture, pneumothorax, bowel rupture, carotid cavernous fistula. And again, these are just all things that you want to educate the patient on. They'll want to have an emergency plan, fill out paperwork, maybe leave it in their car for an emergency situation, or put it by the front door in case of an emergency if EMS has to come. And it's been mentioned as well to notify the care team of the diagnosis, especially with all the different electronic medical records. You do want to notify the providers in different either hospital systems or who have the different EMRs, just so that everybody is aware and on the same page when it comes to the patient care. Medication considerations. I found this to be rather fascinating when I was doing my research. So fluoroquinolones, generally speaking, should be avoided because there's already an increased risk of aortic aneurysm and dissection. So even more so if you have somebody who has a connective tissue disorder, one of the heritable thoracic aortic diseases. I've heard it mentioned actually sometimes to put the fluoroquinolones on an allergy list, of course, typing in the reason why. And there's actually going to be a debate on this at an upcoming conference, which I think should be fascinating. Calcium channel blockers overall should be avoided. They were actually found to accelerate aneurysm expansion, rupture, and premature lethality in Marfan mice. Angiotensin receptor blockers, on the other hand, were actually found to dramatically slow aortic root growth in children with Marfan syndrome who previously had rapid aortic root growth. So you'll find that a lot of the medications that people are started on, especially with the syndromic HTAD, is a beta blocker and an ARB, while avoiding the calcium channel blockers. Risk factor modification, and this just goes back to the basics, telling people to have their blood pressure under control. If they're smoking, all the more reason to quit. Moderate exercise is advised. So if you have an HTAD, it is not advised to do things like really heavy weightlifting or contact sports. You'll probably want to avoid hockey, American football, those kinds of things. Okay, so you're all probably wondering, how do we order the genetic testing? There are two major options. You can either refer to a cardiovascular genetic counselor, preferably at an expert center, or providers can actually order the genetic testing on their own. You'd want to go for the aortopathy panel. I've used Invitae before. There's also Ambry Genetics and there's GeneDx. So I know for Invitae and Ambry, providers can actually set up their own portal. You order everything online, you get the results sent to you. It's pretty user-friendly, pretty easy to order. Again, if you know what you're looking for and you're comfortable, you can certainly order this on your own. If you don't have that comfort level, obviously that is okay. I would refer again to a cardiovascular genetic counselor. So when you get the genetic testing results, there are 5 different categories. the test is either going to be benign, likely benign, pathogenic, disease-causing, likely pathogenic, or the VUS. I like to joke that the variant of unknown significance is also known as the bane of genetic counselors' existence. I hope some people find humor in this. They are things that are found quite frequently. I've heard that anywhere between 70 and 90% of these VUSs are eventually reclassified as benign or likely benign. There are a lot of genes that have not been found yet that could cause the HTAD. So some of the VUSs will, eventually be reclassified as pathogenic or not pathogenic. Again, more likely to be benign or likely benign. And there are genes, out there that have not yet been discovered. And just want to point out, going in line with what I just said about the VUS, our ability to detect genetic variants far outweighs our ability to interpret them. So again, just want to stress the refer to a genetic counselor, especially if you do have a VUS. Even if nothing pops, so to speak, even if you don't get a VUS, if they're all just negative, if you strongly suspect HTAD and the person has a strong family history of these major aortic events, I would still refer to a genetic counselor because there could still be a familial aspect to them. And also it would be prudent to have their relatives, the first and maybe second degree relatives, undergo monitoring either with an echo, CTA, or MRA, and that will depend on, the history of the person who's had an acute aortic event. For the VUS, there is really strict criteria to reclassify them. From my understanding, I think it takes a long time to reclassify them. And I believe that we actually have a genetic counselor on. So any questions that you have regarding this or any of the other more specific things, we can ask our genetic counselor at the end. So we'll definitely want to refer to an expert center for patients who have HTAD. There are improved outcomes for these patients. And again, I know I mentioned before that multidisciplinary expert, team approach comprised of geneticists, cardiologists, CT surgeons, vascular surgeons, pulmonologists. Again, somebody might have a spontaneous pneumothorax. Good to have a pulmonologist who knows that the patient has an HTAD. General surgeons, you can get that spontaneous bowel rupture. You can have uterine rupture. So you'll want to have all of these people on the multidisciplinary expert teams. You might be asking, how do I find an expert center? This is my section also called Google is your best friend. So I tried this for a couple of different states. You actually just go into Google, you type in aortic center, aortopathy clinic, genetic aortic center, or cardiovascular connective tissue disorders. And, the closest centers to you will pop up. I will say that not everybody will want to be referred to an expert center in the sense that sometimes they're just too far away. Sometimes there are insurance issues. So this is one of the reasons that I'm really passionate about educating people about these HTADs. So I do think it's important for everybody who works in, cardiothoracic surgery, vascular surgery, cardiology, to at least have some kind of baseline knowledge on when to expect the HTAD so that we can see, if they do have the heritable thoracic aortic disease. But I've had a couple people, with HTAD or VUS who actually just haven't wanted to be referred to an expert center because it's either too far or it's an insurance issue. And now we'll go over some resources. And these are resources for healthcare professionals, researchers, and, our patients, the affected individuals. I'll just go through these rather quickly. I'm not going to, click on each and every website, but I do have the link included below, and I just have a general description of all of these resources. So the GenTech Alliance is an excellent resource for patients and providers alike and other healthcare professionals. They have a lot of really great educational videos. If you want to learn more, I highly suggest checking out their website. We have the International Registry of Acute Aortic Dissection, also known as IRAD. It's a consortium of these expert research centers. evaluating the current outcome and management of acute aortic dissection, as well as intramural hematoma. They're really doing a lot of research. They also help put together a biannual huge aorta conference, which I'll touch on next. So it's the GenTech Alliance and IRAD. They're putting on a big conference this summer called the Tromso Aorta Conference. This is the one that is every 2 years. So the mission is to share current knowledge on the underpinnings of the genetic aortic disease. They review current best practices. I know that they'll have some debates as well related to current diagnosis and treatment. And they're fostering this educational exchange between scientists, institutions, lay organizations, and anyone else interested in these genetic aortic conditions. Dr. Shireen Shalhoub is actually creating a one-day HTAD genetics course, which I'm super excited about. It's planned for September of 2025. There's no date set in stone yet, but do stay tuned for details. And I also do just want to make a plug for the International Society for Women Vascular Surgeons. They do have affiliate memberships for APPs, and since 40% of the SVN membership is APPs, I did want to mention this. They also just had their Women's Vascular Summit in Chicago. It's a yearly conference. I went last weekend, really learned a lot, so I would definitely suggest checking out that conference, of course, as well as the upcoming SVN conference. There is a UT Health Adult Cardiovascular Genomics Certificate Program. I have not done this yet, but it sounds fantastic. And I also just want to point out that it's free. There's a focus on adult cardiovascular genetics, and they're addressing disparities in access to the genomic education, which, as we have seen, has been confined to pediatric and cancer genetic programs. As a matter of fact, when I was looking for a geneticist to refer my first patient to, there was no cardiovascular geneticist, really in the area where I live. But there was a big focus on the cancer genetics. So the goal is to fulfill an unmet need for adult cardiovascular genetics education locally, nationally, and internationally. I think that this is a great resource, and again, it's free as an added bonus. We have the VASERN, the European Reference Network on Rare Multisystemic Vascular Diseases. They also have a lot of really educational videos. A lot of them are really short, 4, 5, 6 minutes. So if you want a quick snippet of education, these videos are fantastic. Marfan Foundation, some of you might have heard of. They have some upcoming walks for victory as well. They have one in Michigan that's just coming up next month. They have a lot of resources, again, for all healthcare professionals as well as patients. There's the VEDS movement, obviously specific to vascular Ehlers-Danlos syndrome. There is the Ehlers-Danlos Society. Granted, this is more generally about Ehlers-Danlos syndrome, all the 13 subtypes, as well as hypermobility spectrum disorder, but vascular EDS is one of the subtypes. So you can find some valuable information here. I did the EDS Echo for Clinicians program from the fall to the spring and learned a lot of valuable information that I'm using now in my clinical practice for screening for HTAD. You have the Loeys-Dietz Syndrome Foundation. You have Aortic Hope, and I do want to point out, hopefully you can see this. I know it's a little blurry, but it's actually a booklet. You can request these and they will send them for free. And it is a booklet on a guide for aortic dissection. It is just full with really good information. It's almost 100 pages. It has really nice visuals for patients, and it lays things out in a way that I think is really easy to understand. There's the John Ritter Foundation for Aortic Health, another great resource. Most of you probably are familiar with John Ritter. He was a famous comedian. He unfortunately passed away in 2003 of a thoracic aortic dissection that was originally misdiagnosed as an acute MI. So after he passed, his wife started the John Ritter Foundation for Aortic Health, and They fund research. They have webinars. I've watched some of their webinars. They're very informative. And while we're on the subject of famous people who have passed because of dissections and aneurysm, Albert Einstein and Lucille Ball, they both passed from an aortic aneurysm. And Alan Thicke, who passed, I think in 2016 or maybe 18, he actually had a type A aortic dissection and he was only 69 years old. This is a really interesting app that I recently found. It's a genomic medicine guidance point of care tool where you can actually put in the specific gene and the variant, and it will just pull up all of the information for you on the guidelines for diagnostic testing and imaging in terms of the frequency of the imaging, surveillance guidelines, medical therapy, exercise safety, even management during pregnancy, and then when to do the elective surgical repair. And again, this is something you can just pull up on your phone. It's phenomenal. The ACC/AHA guidelines, these are fantastic. It's pretty long. The guidelines are about 150 pages. I think there are about 20 solid pages on HTAD. I just print it out and carry it in my work bag, so I always have it with me. Wonderful reference, not only for HTAD, but as you can see, generally the management of aortic disease. So in summary, always ask about family history. Make sure to refer the HTAD patients to expert centers. And as we just talked about, definitely reference the ACC/AHA guidelines. You can just pull them right up on the internet. The PDF is right there. Great guidelines for the diagnosis and management of aortic disease. And you can also see they're really recent. And the medical management of patients with HTAD, like almost everything else in medicine, right, is not one size fits all. So you really do want to think about the family history, the particular genetic variant, etc. And one thing I didn't put in any particular slide, but I thought it was interesting that the guidelines actually recommend that surgeons put in their op note and then in one of their progress notes or the discharge summary, the size of the aneurysm before they repaired it. Reason being, if you have somebody who had an aortic rupture, let's say, when their aorta was 4.2 centimeters, that's going to be useful information for other family members who might also have the pathogenic variant and are going through that surveillance testing. For them, you're probably not going to want to wait until it's 5 centimeters. So having that information on the family history and these specific measurements is actually really valuable. And I do want to point out, going back to the always ask about family history, if you have a patient who's 85 and they have a thoracic aortic aneurysm, I still do ask about family history. I don't just chalk everything up to, older age and hypertension. And granted, statistically speaking, we are not going to see the HTAD very often, but it can be missed if you're not asking the right questions. I did have a patient once where, she was an older woman and I was asking her about her family history. And she said, oh yeah, my father had, sudden cardiac death. They didn't do an autopsy, it was a long time ago. So no definitive diagnosis for that. But she said that she also had 2 cousins who had an aortic repair. I don't think she knew offhand if it was the like ascending aorta or the descending thoracic aorta. So we had a discussion and I advised her to, just mention this to her kids. They lived out of state, so not anybody that I was going to bring to clinic, and just say, hey, make sure that they mention this to their providers. They should at least get a baseline echo and maybe a CTA or an MRA. Flip side too, you could have somebody who's 25 years old and they go into the ED and they have an ascending aortic dissection. There are other things that could cause that. Somebody could have, a horrible infection that could cause a dissection. Somebody could have, let's say, a bicuspid aortic valve that could cause that aortic dissection at a young age. So one of the keys is just taking a really good history and looking at all of the variables and definitely referencing the guidelines. Thank you, everybody, for your time and for listening. Any questions, any kind of discussion? Would love to answer some questions.
Thank you so much, Heather. That was great. I especially appreciate all of the resources because it's a lot, right? So for those of us who don't see this or, have the same expertise that you do, we're lucky to have Heather. So basically every time we have a question, we just say, Heather. But those were really great resources. So we can all go back and look. If you guys do have questions, please put them in the Q&A and then we'll go through them that way just so that nobody feels like we have to try to kind of compete for airtime. So we do have one question already. This is from Laila Mahmood. When you said moderate intensity exercise is recommended for patients with these conditions, are there any more specific recommendations of exercises or methods to either do or not to do, such as swimming, resistance training, etc.?
So swimming and walking, I've heard are really good methods of exercise. Weightlifting, from what I've heard, is a definite no. What was the other example of specific exercise?
Resistance training.
Resistance training, probably not. This is something that's going to be, discussed more thoroughly and debated at the Tromso conference. So I don't want to give 100% answer on everything, but if there's resistance training and there's any heavy weightlifting involved, or basically you're putting pressure on the aorta, I would say err on the side of caution.
Awesome. Also as a side note, along with Heather, we do have Molly, I think, who we have unmuted. She is a genetic counselor and is also available for questions. So if you guys have any questions regarding the genetic counseling, thank you, Molly, for being present. And maybe we'll give you a couple minutes if there aren't other questions and let you share some expertise if you want, no pressure. Another question that we have is, can genetic testing for this be done by swab and mail in?
Oh, yes. I'm sorry. I was going to share here, I'll try to share it now, actually. Can you see this, the test catalog?
We can't, so we can still see your screen, but maybe we can do it for that. Talk through it, and then we can maybe send out to the participants the PDFs of your examples.
Perfect. So if you want to order the testing yourself, if you're a provider and you're going to go into the portal, you have a couple different options. You can have the companies send these, swabs, or the saliva collection kits. You can have them sent to your office and just have them ready to go. The blood draw is a gold standard. Also, if you do the saliva test kit in the office, you want to make sure that they haven't eaten or drank anything 30 minutes prior. That is certainly an option. With the genetic testing, you can actually have an option to also have the kit sent to the patient, so they can either do the saliva at home, just, spit into that little vial, put it into, the container, and they have a prepaid envelope and you drop it off at FedEx. They can also get a blood sample with the vial sent to their home. And at least I know Ambry and Invitae have a third-party provider where they have a phlebotomist go to the patient's home to actually do the blood draw, which is nice, especially for the people who are more homebound or they're working full-time. It's just one less appointment that they have to make. But they don't do swabs, but they do the saliva or the blood collection, the blood draw.
So no other questions right now, but I actually want to ask one or share one because we had the question, like you touched on cost a little bit, but hypothetically, Kristen's in clinic, she sees a patient with those, the phenotypes, and she's like, man, I'm going to do this. I'm going to order it, goes through Invitae, orders it, does all of that. What have you found the cost to the patient generally to be on average?
So I don't hear back from most patients on, what they ended up paying out of pocket. But I can tell you most people, 90% will end up paying less than $150. At least I know with Ambry and Invitae. There was one patient that I had who ended up unfortunately paying about $450. He was not made aware of this beforehand. I think that higher cost, likely from what I understand, was because he had private insurance. So I do give the disclaimer that although it is a lot less expensive than it was a decade ago, it still could be a couple $100. And the companies do have payment plans as well. And in certain cases, I have heard that they might just waive the fee depending on the person's financial situation. So there are options as well.
Awesome. Thank you.
Yes.
Okay. Heather, with Molly being such a great resource, and Molly, definitely do not want to put you on the spot. There's no obligation whatsoever. But what are some of the things that like uniquely you think, you know, between the two of you with Molly or genetic counseling you could share? I know one of the things that we get is, like you talked about a lot, the variants of unknown significance and kind of what we do with that. Just in a couple quick minutes, what would you say with regard to that?
Yeah, no, you're not putting me on the spot. It's been a pleasure to get to know Heather, and Heather, great presentation. It was very comprehensive, and I appreciate your presentation style a lot. It was really thorough. I'd say what I had noted was, along with just reaching out to the labs, I really encourage you to consider yourselves a partner in diagnosing the patient through molecular testing with the lab. We want those medical records if they've had diagnostic imaging. We want as many details as possible, because as part of the criteria with the HCMG and AMP guidelines, yes, we can look at how rare is the variant, what's the effect of the variant, have we seen it before, and we know, with confidence it's likely to be pathogenic. Every patient we test could be eligible for meeting, case report criteria, where we can weigh that rare variant a bit more heavily if we were to know that they have this really specific phenotype that's essentially pathognomonic of an HTAD. So this is my call to action of, we would love the records as commercial laboratories. We're also very invested in learning from patients who have tested positive and what variant properties are, enriched in their pathogenic variants versus patients that perhaps have the phenotype but are presenting with more phenocopies and are more likely to test negative. So there are a lot of exciting efforts for resolving uncertainty. Yes, as a genetic counselor, I thought that was quite humorous, in that, they're frustrating, but fortunately they are being resolved at a faster rate as our understanding advances and as we test more patients. And we're here as resources, genetic counselors, and so we want to make sure you feel supported and not let the idea of getting a VUS back deter from the valuable information you could gain from having a molecular diagnosis through genetic testing. So I appreciate the opportunity to share a little bit more from my perspective.
Oh, and I forgot to add as well with the genetic testing. I know for Ambry and Invitae, and it might be similar for some of the other companies, that the patients they can discuss their results with a genetic counselor, and that's built into the cost of the genetic test. So I believe it's, 30 minutes. They can just set up an appointment with a genetic counselor to go over the results. And also wanted to mention that the cascade testing, at least that I have found so far, is actually free to first and sometimes second degree relatives. And that's only if, and correct me if I'm wrong, Molly, but I think it's just for the pathogenic variants that the cascade testing is free for the relatives. And that's I think that's a really nice service to do.
Yes, that's a really good resource to bring up. Family follow-up testing being valuable from, if you have a likely pathogenic or pathogenic variant, of course, cascading out from there. But then also with regards to those VUSs, if there are similarly affected relatives, most commercial laboratories will partner and recommend, resolution studies where, if we could determine that the variant is segregating enough times in similarly affected relatives across generations. So enough times, meaning it's not just by chance that they inherited the variant, that could be enough additional clinical observation data to upgrade the variant. Or for highly, early onset, highly penetrant conditions, we could downgrade the variant to benign. So again, really investing as a partner in helping us resolve them. We appreciate the follow-up work, recognizing it's another step to reach out to relatives, but we value the additional clinical data so much.
Awesome. Wonderful. Thank you all so much. Thank you, Molly, for adding that great presentation. Heather, thank you so much for sharing your passion and your expertise with us. Thank each of you for being here this evening. Please watch your email for that post-webinar test so that we can get you your CEU, and stay tuned for social media and email updates if you are a member on all of our upcoming events. Everyone have a great evening. Thank you so much for being here.
Thank you, everybody.